We're going to have our wonderful virtual talk by Dr. Garg. I'm going to introduce him, and I must say that he has a daunting 43-page CV, but I will try to summarize that in a couple minutes. He is professor and founding chair of dermatology at Northwell Health and professor at the Feinstein Institute for Medical Research. Further, he has served as Northwell's dermatology residency program director for the past 12 years. Dr. Garg is also president of Northwell Health Physician Partners, one of the largest integrated medical groups. He earned his medical degree at the University of Massachusetts and completed his dermatology residency at the University of Illinois. Dr. Garg began his academic career at Boston University, serving as residency director for his last 5 years at that institution before joining Northwell. He's nationally recognized for his leadership in dermatology, and his contributions span clinical care, education, health policy, and outcomes research. This has included serving on numerous committees for the AAD in these subject areas and speaking nationally and internationally. His dermatologic disease areas of expertise include hidradenitis, psoriasis, psoriatic arthritis, and alopecia areata, to name a few. His scholarly achievements include over 150 peer-reviewed publications, including a measly 70 on hidradenitis alone, 24 book chapters, and 1 textbook. He is an editorial board member for the JAD as well as for the Annals of Internal Medicine. His commitment to mentorship and education has earned him a number of awards, including the AAD's Thomas G. Pearson Memorial Education Award, and he has served as a long-term mentor to numerous physicians, including our very own outstanding faculty member, Dr. Winnis Tom. His research is centered on inflammatory skin diseases, interdisciplinary care, and advanced analytics to improve patient outcomes. He co-leads international collaborations like the Cord-Cousin collaboration and Historic, which are establishing core outcome measures for clinical trials in dermatology. Today, Dr. Garg will discuss the application of big data science to discovery in hidradenitis suppurativa. Will everyone please give him a warm welcome?
Well, thank you for that very kind and very warm introduction. Although we are virtual, I feel like I have a lot of great vibes with UCSD and the Naval program for a lot of reasons. People I've had the pleasure of working with, even mentoring, as you mentioned. But maybe even my first experiences go back to, gosh, it's been maybe over a decade now. But I was the founding father of Resident Jeopardy at the AAD. And the first winners of our inaugural event were, in fact, the UCSD and Naval program. So big kudos to you guys then. You've been in my hearts ever since. So I'm very happy to have this opportunity to talk about HS, and really by way of it, what big data science as a fairly new research tool has really allowed us to understand about HS and diseases that fit into a similar box. So I hope this topic is of interest to some researchers in the audience, and obviously the folks who are interested in caring for patients with HS. So we're going to talk about how we've used big data to really try to solve some real clinical dilemmas related to this disease. And of course, I'll offer my sort of treatment strategy. And I hope we'll leave plenty of time to talk about really anything you want related to HS. I work with several companies. None of it is really on the commercial side. But I don't know, I'm usually at talks where people try to gloss over this slide really quickly. I'm in fact very proud of it because every company listed here has been invested in the HS space and really trying to fill and meet what I believe is one of the greatest unmet needs in our specialty, which is treatment for HS. And my work with them has been in helping to develop and tighten protocols, which allow us to better highlight the efficacy of drugs, separate that efficacy from placebo. That's been a big problem in HS trials, and that's one of the reasons why, to date, treatment still remains an unmet need for HS. So my work here is really helping to try to address that problem. I'll also kind of give you a little bit of background of how I became interested in HS. I probably really started thinking more about HS maybe only a decade ago. And it was really when I had the privilege of being able to start a new department here in Metropolitan New York at Northwell Health. And this was a scratch start department. In fact, one of the images there is a list that I made with an administrator that I was paired with on my first day of work, really now about 11 years ago. And it was this spiral notebook on a really raggedy desk and a list that is as raw as it gets when you think about just starting from scratch. It was finding space, ordering some supplies, hiring someone to room the patients, hiring someone to answer the phones, and even finding patients to see. It's been an incredible journey. A few short years later, we are a fairly big department of over 50 faculty. With a residency program, we have 15 residents, and really involved in research, clinical research in a lot of ways. So really a full thickness academic department. But I'll tell you, the beginnings were extremely humble. But one of the benefits was that we have no concept of what this is today, but we actually had the luxury of time in seeing patients, because when you first start a practice, you have that luxury of time. You have fewer patients, and you have the opportunity to spend more time with them. And some of the first patients that walked through our doors were people who were really struggling with their disease. A lot of HS patients who just weren't able to get the right care, sometimes even the right diagnosis, much less, the right sort of understanding of their disease. And of course, just some semblance of treatment that would help their symptoms. But when you ask just one extra question, one open-ended question to an HS patient, you really get a compelling story and journey that you just, as a physician and as a dermatologist, you can't ignore. And it was at that time that I decided that if this department was going to do anything, we would, really dedicate and allocate a significant amount of expertise, but resources to, of course, caring for these patients, but really in trying to understand this disease better than we do. And that's sort of how I became interested in really trying to understand this disease differently than we had. So I'm going to talk about how big data has helped us do just that. And there are many sort of aspects of my research that has involved big data across inflammatory disease and even within HS. But I thought I would focus on these three topics, of which, I think there were really a lot of gaps in information. Has helped us understand this disease better, and I think has helped us care for them a little bit differently. And let me tell you a little bit about our workhorse engine, which has been an IBM database called Exploris. And I think really just as a data structure, data quality, data analytics, forming hypotheses to answer scientific questions, using big data in and of itself is a talk, and I'm not going to go through all those details. But I would say overall, I think the main benefit of a big data platform like Exploris is that it combines power, number of observations, so like what you might see in a claims database, so lots of unique lives covered, with granularity of information like you would see in an EMR. And when you can combine both power and granularity of information, then it makes characterizing a disease in a more sort of robust and detailed way meaningful. Prior to this, our cohort sizes of HS patients were, believe it or not, as small as 50 patients, but maybe as large as 5,000 patients. And it's just very hard to study an uncommon disease. And even beyond that, rare events within an uncommon disease with sample sizes that are that big or that small, and with lack of, real granularity of information. But Explorers has allowed us to overcome that one problem. We've been able to validate a cohort of well over 70,000 HS patients, and then also have, with that number of patients, all the information you'd be able to find in an EMR about them. So that really was a meaningful change in the way that we were able to understand the disease. Different from, let's say, a disease like psoriasis, which we were at least 10 or maybe 20 years behind the curve on, namely because psoriasis is much more common, and your ability to gather and characterize patients with that disease is just much easier than a disease like HS. So let's start with disease burden. And let me start with, essentially, what amounts to prevalence and incidence. And I'll tell you, throughout residency, even as a junior faculty, I used to just have a big eye roll every time we would read a prevalence article in Journal Club, because I was like, what's the big deal? But I'll tell you that understanding disease burden for dermatologic conditions, especially one like HS, is so critically fundamentally important for so many reasons. First off, it just creates awareness, and HS is a disease that still suffers from a total lack of awareness in both medical and public sectors. It allows you, when you understand the prevalence and the subgroups of patients that have the disease, it allows you to then identify segments of the population who are at risk or who are at greater risk. That then allows you to plan and deliver services for those patients at risk. You can develop a health agenda with the appropriate allocation of resources once you know how common this disease is and who gets it. And then you can really move on involving stakeholders around education, around advocacy, around research agendas, with funding that can really help then address a lot of the gaps. So a lot of things flow from just understanding disease burden. And so you still might eye roll, and I still sometimes do, but I have a much better context with which I approach those articles, because I can see sort of not just what the paper is saying, but then what something like that paper ultimately implies for the patients with that disease. So the problem with HS is the disease burden has been quite controversial. We've had ranges in prevalence from all the way down to 0.05% to what's that, 2 orders higher, 4%. And 4% is a number that's a higher estimate than even psoriasis, which just seems impractical. I don't think anyone believes that HS is more common than psoriasis. The problem is not in so much that the prevalence really does vary so much throughout the world. I think it more relates to our method of basically acquisition of the data. The two major methods we use are a self-report by patients, where we ask them to describe their symptoms, and there are a couple questions that are fairly specific to HS, and that's one method of trying to ascertain prevalence. When we do it that way, though, it seems that the prevalence is overestimated. So when you see prevalences for HS in the ranges of 2 to 4%, it's usually because it's been a patient-reported sample. And this is not unique to HS. We see this across derm diseases and other diseases in medicine. But when you ask patients if they have acne, when you ask them if they have eczema, when you ask them if they have vitiligo, the prevalence estimates are far, I would say, greater than other methods of acquisition. The other main method is by our diagnosis as clinicians, where a patient would come into your clinic, you would evaluate them, you would diagnose them HS, and you would code that in your EMR. The problem there is that it relies on patients coming to the care setting, seeing the right physician who can diagnose the problem accurately, and then that physician coding it accurately. I mean, how many times have you coded eczema as dermatitis, right? So there's a lot of even misdiagnoses or lack of specificity in diagnoses, even when the patient shows up, to the right place. So we found that when we try to ascertain the data by physician diagnoses, the prevalence is underestimated. The truth is, we think the prevalence number lands somewhere between, at least in the United States, 0.1% to 1%. That's still not a trivial number. If you can imagine 1 out of every 100 patients walking around on Earth has HS, that's a huge burden. So the truth is probably somewhere in that range. We looked at the prevalence in the United States, and this is probably the largest population-based group that's been sampled in the US. And this is by physician diagnosis. And so not surprisingly, our number lands at that 0.1%. But I think what's probably the real reason why we did this study is really in the subgroups. Well, we know women get HS more often. We know younger patients get HS more often. We've seen that in our practices. We've also seen in our practices that Black patients very frequently have HS. But if you were to look at the prevalence data that existed to date prior to this paper, you would actually never think that a Black patient could even get HS, because the prevalence numbers were so low if they were even reported at all. And the problem with it is that literature mostly came out of Europe. So this was the first time where we had data that signified and quantified that Black patients were disproportionately getting HS. And that actually reflected our clinical experience here in the United States. And so it was an important quantification that this paper allowed. Okay, next is time to diagnosis. So when we ask HS patients, what is the timing from when you hear or when you develop your symptoms, boils, to the time you hear the words hidradenitis suppurativa? And on average, when we asked thousands of patients, that time was 10 years, which is pretty staggering when you think of the heavy symptom burden for a disease like HS. And also pretty staggering when you think about what happens in that 10 years. Patients have diagnoses that are incorrect or inaccurate. They have treatments that are suboptimal or just flat out wrong for what they have. And at the very least, they have really fragmented care bouncing around from one doctor to the next, being misdiagnosed and suboptimally treated. And probably in that 10-year window, before they even get to you as the dermatologist, probably in that 10-year window, there's significant progression of disease. And that probably accounts for when a patient finally does present to the dermatologist, we're usually seeing them at pretty advanced stages. So this has been a major issue because we feel like the right time to treat HS is at its earliest stages, when our treatments have a chance at adequately controlling symptoms and ideally modifying or preventing altogether progression of disease. The issue, though, is that most of these patients, in thinking that this is some kind of infection, thinking it's an STD, thinking it's not really a dermatologic problem, don't necessarily present to the dermatologist when they have these symptoms. And sometimes just have a hard time accessing us, even if they wanted to come to us. And so these patients largely are presenting to the EDs for acute care, sometimes being hospitalized, seeing their OB, seeing the urologist, seeing a general surgeon. And those doctors just aren't that familiar with this condition. They may not have even heard the words hidradenitis suppurativa anywhere throughout medical school, and maybe not even throughout their training, much less have seen cases and been instructed on it. And so you don't learn about it in medical school. And frankly, other doctors, we can't expect them to be expert in the morphologic exam where they can really easily distinguish an abscess from true abscess and an abscess from what you would see in HS. So then it's not so surprising, right, that we have this delay in diagnosis. So we've approached this problem by thinking about how can we create an algorithm that does not require any kind of physical exam, that does not even require the physician to have heard the diagnosis hidradenitis suppurativa, to evaluate the patient at the bedside and have a prediction score tell them about this diagnosis and what the likelihood of it is. And to do this, we used, again, our big data analytic platform, where we took thousands of patients with HS and thousands of patients with its closest mimic, cutaneous abscess. And not just any cutaneous abscess, not one on the finger, for example, or even on the face, but one in areas that might be confused with HS, the axilla, the groin, the perineum, the buttock, so high specificity sites. And what we did is essentially we took these two groups and we leverage what we know are known associations with both conditions. And we said, which ones of these really stand out? Which ones can be really heavy on the side of HS? Which ones are really heavy on the side of abscess? And which characteristics can we put into an algorithm to really then exploit those features, those historical features, that any physician can use to understand that the condition before them may not be an abscess. And there are lots of these that are listed here that are associated with either condition, some of which are stigmatizing, and we felt it only right and fair to not have those as part of any kind of case identifying sort of predictive algorithm, because it enters into probably the care unfair biases that just don't need to be there. So we've looked at a couple different models of this and have settled ultimately on the second version, which excluded some of these, we call like sort of biasing risk factors. And here's the performance of this HS CAPS model. You have here a curve where the perfect diagonal line is where the number of observed cases meets, or the number of predicted cases would meet the observed cases in a 1-to-1 sort of ratio. And you can see here the calibration plot follows fairly closely to that line, meaning it performs pretty well in terms of its performance statistics, and namely sensitivity and specificity. And here's the somewhat complicated mathematical model, but you can see here there are just a few variables that ultimately stand out in differentiating cutaneous abscess from HS. Sex, race, BMI, and historical diagnoses of acne, diabetes, and PCOS. You can see here there's no nodule, abscess, or tunnel listed. You don't have to have any exam qualifications, training, or background to be able to use this algorithm. And you don't even have to do this calculation at the bedside. This algorithm can be entered into any medical calculator. And I'll tell you, like ED docs are very used to using medical calculators, right? There's an algorithm for whether a patient needs a stent or not, whether a patient with community-acquired pneumonia needs to be admitted or not. Why shouldn't there be an algorithm for when a patient presents with a cutaneous abscess, right? So every time a patient presents with an abscess, the ED physician can pull up their MedCalc, open up the cutaneous abscess sort of algorithm, and not do an exam, but just plug in the patient's sex, race, and some historical problem list information. And the algorithm then tells you, hey, this patient has an expert, probability of having abscess, or hey, they might have this probability of having this condition called hidradenitis suppurativa, even if you haven't heard of it. So right at the bedside now, at the first presentation, there is now a different sort of way of thinking about the patient before you. So here's an example. This patient may show up to the ED, 30-year-old male, African-American, higher BMI, no history of diabetes or PCOS, but he's got a history of acne. and the algorithm will tell you that this patient has a predicted probability of having an abscess, and a very high one. And so that physician's diagnosis of abscess is supported by this clinical decision aid. In another case, this is a 40-year-old woman, Hispanic, BMI of 34, has a history of diabetes, no history of acne. And in this case, the algorithm says, well, hey, this patient that you're diagnosing with abscess actually has a very low predicted, sorry, this is probability of HS over, right. So meaning, oh, I think I mixed them up. So over here, we've got a high probability of having HS based on the algorithm. And in this case, the physician diagnosed the patient with an abscess, and this algorithm will support that decision by saying the probability of HS over abscess, in fact, is very low. Right? So this basically takes away the need for a physical exam, which our colleagues, we can't expect that they would be expert in like we are. All right. Then there's comorbidities. We've done really a lot of work in systematically characterizing the comorbid profiles of HS patients, because we would see these patients and we would see all these other conditions that they had. We just never had any way of indicating that these patients have a high burden of these other comorbidities, and we had no way of quantifying really what that burden could be, because we just didn't have enough patients to really pull together and characterize to be able to understand this information. So we started asking just a very simple and broad question. What is the comparatively, what is the comorbidity burden among HS patients compared with obviously the healthy population? But what about compared to psoriasis, which to date had been our prototype skin disease to study the model of inflammation in the skin to comorbid disease? And so what we did is we took those three groups of patients and we used a validated comorbidity index called the Charlson Comorbidity Index. And if we just pull together those three groups and we calculate the CCI score, we see that psoriasis patients overall and across the subgroup populations, psoriasis patients have a higher CCI score than do healthy patients, but than do HS patients. However, if you just simply take into consideration age, sex, and race, right? Your comorbidities vary by your age. Your comorbidity profile also varies by your sex. And unfortunately, in the United States, your comorbidity profile also varies according to your race. And so if you just adjust on those three factors alone, what you see here is that now all of a sudden it flips. Your HS patient overall and across all of the subgroups have a higher CCI score than do healthy counterparts, but then also do psoriasis patients. And this made sense based on our clinical experience. So if you believe that inflammation in the skin and inflammation in the body as it leads to comorbid diseases has a connection, then I would argue that really HS is the prototype disease to study, given the level of inflammation and the degree of comorbidity burden. And so there's a lot to study here, potentially using HS as that model. But what this told us is that the burden for HS patients for comorbidity certainly is present. It involves a lot of different organ systems, which I'll show you. And in fact, the degree of that comorbidity burden is high, perhaps higher than any other skin disease. So we spent the last decade really, as I mentioned, just sort of systematically characterizing that profile for the HS patient. And you can see here almost every organ system is involved. And it's in sort of the analyses, but these are all disease-specific risks, meaning in these analyses, we have accounted for confounders that also lead to these other comorbid conditions, meaning the risk that we see here is attributed to the disease alone, having taken into account the other confounders that are related, for example, to cardiovascular disease or psychiatric disease. So it's, when you look across the body, then it's a pretty compelling picture that's painted here for an HS patient. What I thought I would do is talk about maybe just three of these. The references are there, and I'll lead you to an article which summarizes all of this. But I'll talk about these three because these are actually three of the more common ones that I get asked about from colleagues around the country, but in particular in patients. And so your patients may ask you about these as well. So one is, do HS patients become obese as a result of their disease, or does obesity somehow influence the development of HS? I notice HS in many kids with Down syndrome. Is there some kind of association or link? And for women with HS, how does their pregnancy go and what can they expect from it? So let me dive a little bit deeper into these three clinical questions. The first is a paper looking at trends in body mass index before and after the diagnosis of HS. Now, I think everyone here recognizes that there's a clear link between BMI and HS. However, prior to this paper, all we ever knew was that the two were linked. They were prevalence papers. You would take, 100 or even 1,000 patients with HS, and you would say 80% of them have a BMI over 30. That only confirms the association between the two, but it tells us nothing about the sort of sequence or the temporal relationship between the two, even though in papers obesity had been referred to as a risk factor. We had no data suggesting that even obesity came before HS or knowing whether it came after. So this was actually a pretty important study to undertake because it gave us some sense of that temporality. Now, I just finished telling you that HS patients are diagnosed years after their symptoms. So to do this study right, we needed to take a look at when HS patients were diagnosed, and that's that vertical dotted line at time 0. But then we needed to look several years before that to see what was happening to their trend in body mass index. And what we observed was that even 7 years prior to the time that they were diagnosed with HS, HS patients had a higher baseline BMI than did their healthy counterparts. What we also saw was that that rate of increase in BMI leading up to the time of diagnosis was higher in HS patients than healthy counterparts. And finally, what we then appreciated is that after diagnosis, the weight, the BMI in HS patients actually went kind of flat. Whereas in the healthy counterpart pool, there was still a slow uptake, meaning with time and with age, BMI in the healthy population still continues to increase. And I don't know, I would say that that's probably true for me, and that's probably true for most Americans. But in HS, we actually saw that stabilize. So what this told us was that actually at baseline BMI, even years prior to the diagnosis of HS, and the rate of increase in BMI leading up to the diagnosis of HS were in fact risk factors for the development of the disease. And in various sub-analyses, we found that the influence of BMI was in fact greater in women and also greater in younger patients, both demographics in whom HS is disproportionately involved. And then we also saw from this study that BMI tends not to increase so much in HS patients after their diagnosis, probably in some level related to the counseling that we do and the literature that HS patients even become aware of as it relates to relationship of BMI, to HS. So what does this mean? Listen, I think what it suggests is that BMI is in fact an influence and probably a risk factor in the development of HS. Is it the case for every patient? Absolutely not. Is it the case alone And for sure, it's not. We know that there are many other risk factors for developing the disease, including tobacco, the data for which I'm not showing you here, as well as factors we're not even aware of yet that are very likely involved in the incidence developing the disease. And therefore, for a group of patients who are already heavily stigmatized, I just always try to emphasize this is not a conversation that I like to have early on with my patients. And even when I have it, I also make sure that I'm contextualizing it in a way that makes sense for a patient and that is fair for a patient. So I tend not to address this topic until I've got a pretty well-established therapeutic relationship with that patient where they trust more of what I'm going to say. I keep in mind that they've had 10 years of total mistrust with the healthcare system. And so they may not be willing to want to listen to everything I have to say with open ears in the first visit or even the first three. And that's okay. So I wait till I feel like I've got the right relationship with my patient to have that conversation. And when it's asked, I emphasize we don't know that it's directly involved. And more importantly, I don't know that if all of a sudden your weight corrected, either by mechanical means, a surgery, or with a weight loss drug, that all of a sudden your HS melts away. We know that high BMI has lots of consequences to health in general. And let's work with your primary care doctor on um, on on modifications that will get you to your overall health goals. And let's see how that does for your HS, right? So it's good for your overall health. And if HS adds some extra motivation, let's work on it. And I'm going to support you on it. But that's the extent to which I ascribe, BMI as it relates, to HS. Okay. I know your PEDS group is away at their meeting, but I would imagine that many of them are coming across this scenario. And we were too. And this is why we wanted to evaluate this and try to quantify it. But we were seeing a lot of kids with trisomy 21 who had, in fact, HS. And so we simply asked the question, what is the relationship between the two conditions? And you can see here, we've got thousands of patients with HS thousands of patients with trisomy 21, and of course, a large group without. And what we saw here was that the prevalence of HS among patients with trisomy 21 was 2%. And I just told you in the general population, that prevalence number is like 0.1%. So this is a significant increase. And just in general, 2% of a group of patients having one disease, that is a huge overestimate. And even when you work in all of the potential confounders, we saw here was that the risk of a trisomy 21 patient having HS was 5 times higher compared to non-trisomy patients. That puts HS squarely as the strongest sort of related skin condition to trisomy 21. So strong that, in fact, whenever I see a patient with Down syndrome, even if they're presenting for their acne, I'm asking them so that if I can take a peek under their arms, under their breasts, even in their groin, to try to screen for HS because the risk is that high. What we also noticed was that patients with Down syndrome were getting diagnosed with HS much earlier on in their life trajectory than were the usual HS patients. So the blue bar graph shows the sort of prevalence by age group category for the non-trisomy population, and then the orange curve, the bar curves are for patients with trisomy 21. You can see it's shifted left. Now, it could be that trisomy patients just have higher surveillance. Maybe they're visiting the doctor more often, and therefore it's getting picked up earlier on. But there's probably a different basis accounting for us than just surveillance bias alone. We think the hypothesis is there, in fact, may be a genetic link between the two conditions that's accounting for its earlier onset, earlier presentation, and therefore earlier diagnosis. So one hypothesis is involvement of the gamma secretase gene. And gamma secretase has a couple of functions. It has several functions in the body, but as it relates to these two conditions, for trisomy, what it does is it cleaves APP protein into amyloid and beta proteins. And in the way of HS, it cleaves the Notch receptor to form the Notch intracellular domain. That domain translocates to the nucleus and is involved in transcription of factors that influence the microbiome, factors that influence epidermal differentiation, and factors that influence immune dysregulation. So when a patient has trisomy 21, you have an incredible buildup of the APP protein. So much so that what we think is happening is that all of the attention for gamma secretase is diverted to cleaving APP protein. And in doing so, Notch receptor sees essentially what is a functional loss because all of the attention is diverted to this other heavy workload. And in that way, you basically are influencing Notch receptor cleaving, and therefore then its downstream effects. And that's how we think, or at least is one hypothesis as to why trisomy 21 patients ultimately develop HS. Okay, and finally, pregnancy outcomes. So look, this is a disease that affects women in their peak childbearing age, and predominantly women. And it's a very common question among my patients. If I become pregnant, what happens to my course of pregnancy? And so it was really born out of patients really asking this question pretty frequently and us not really having any data around to be able to answer this question. So what we did is we took approximately 2,000 pregnancies among about 1,600 women with HS, and we compared their pregnancy courses and outcomes to women without HS. And we included all of the, main confounders that could also influence pregnancy outcome. And there are several comorbidities that can influence one's pregnancy outcome. And what we saw here, there's a lot on this slide, but maybe just let me draw your attention to the columns on the right. And let's first look at that inner one, age and race adjusted odds ratios. We see here that when you just adjust for age and race, you see here that women with HS have 20 to 60% risk of various adverse pregnancy outcomes from spontaneous abortion, preterm birth, gestational diabetes, gestational hypertension, preeclampsia. But we just said there are a lot of other comorbid conditions which could influence these outcomes. And so we want to account for those in a statistical model anyway. And when we do, we see that still spontaneous abortion and gestational diabetes are elevated. And so, at about a 25% higher risk. But I always remind patients, that's really a statistical model. In the real world, I can't just adjust for one's diabetes and hypertension. If a patient has it, that's what they have. And so really, to me, the age and adjusted risk is the real world risk. And you can see here the real world risk of an adverse pregnancy outcome for a woman with HS is fairly high across several potential adverse outcomes. So now I've started to really think carefully for my female patients who become pregnant. Does it warrant having care with maternal fetal medicine, more high risk OB than with usual OB? Because we know the risk of adverse outcomes is higher across many of these conditions. So in fact, most of my patients who do become pregnant, we work with MFM for their care. So I kind of showed you a body map of all the comorbidities involved. That work and work by others has allowed us to actually provide an evidence-based guidance on comorbidity screenings for patients with HS, and it's the first of its kind in the world. And it's a pretty long article, but in that article, and this is open access, you guys can access it anyway. There are some nice tables in there which really summarize the evidence to support comorbidity screenings for all the different comorbidities, but more importantly, what the dermatologist's role in that should be. There are a lot of comorbidities in there that frankly I'm not really expert in screening for. Like I don't know how to screen for PCOS that well. I know that HS patients are at a higher risk for it, but I think that screening is better done by another type of physician. So it lays out in the tables what dermatologists can and should do, but what really should be in the hands of our interdisciplinary colleagues, and even on what level or what frequency it should be done. What I will say is that many of my colleagues around medicine still haven't heard of HS and certainly aren't aware of the comorbidities that can afflict patients with it. And so even though I'm not necessarily screening for those comorbidities, I am serving as an advocate where I might task my primary care colleague in the EMR, hey, this patient has HS. You may not have heard of it, but here are the things we need to look for. And so even if I'm not screening for it, serving as that advocate has been really helpful for our patients in getting the care they need. Okay, and just a couple minutes on treatment. It's really, this slide used to read more art than science. And in fact, that's a lot of what we do in dermatology. If you think about the number of off-label prescriptions you write, that's only because everything is still more art than it is science. And that's a lot of our specialty. And that was the state of HS. But I feel like over the past several months, I was able to flip that fairly to talk more about science than art. And I'll kind of explain, how we've come to that now. There are two concepts that I think about when I think about treatment in HS. It's flipping the therapeutic ladder and it's the treatment toolbox. I first learned about flipping the ladder in medical school. It was the right side up ladder is, you have a condition, you want to start with treatments on the lower rungs where they may not work as well, but their safety profile is really good. And if that didn't work, you would move up the rungs where you would gradually take on some risk with the benefit of having higher efficacy. In HS, we don't really have that time. Think about HS as a progressive, debilitating, deforming disease that 15% of Americans end up on disease-related disability for. If you're trying to treat the patient when they're at a Hurley 3 with lots of tunnels, lots of nodules and abscesses, you're just not going to get there with any treatments we have today. It's really incumbent upon us to find those patients as best we can early on and to treat them with the best medicines we have early on. So that's flipping the ladder. Then there's the treatment toolbox. A couple weeks ago, I helped my son build his new homework desk. We had a toolbox, and in that toolbox were a lot of tools. And we weren't using each tool sequentially. It's not like I did the screwdriver work first, then I did the hammer work, then I pulled out a wrench. We were together. We were using a screwdriver, a wrench, a hammer, all together. Okay? And that's what really HS treatment requires today. It requires different types of treatments with different mechanisms of actions without overlapping toxicities that we use together at the same time, not sequentially, to get the project done. Okay, and so when you think about treatment of HS with those two concepts, it allows you to approach the patient before you with the right level of aggressivity and with the right tools at your disposal used in sequence. So here's what I do. For early disease only, and to me, that means no tunnels and no rope-like scars, so just nodules and abscesses. I think it's okay in those instances to start with a wash, benzoyl peroxide. I kind of like, it drives me a little crazy when I see benzoyl peroxide, clindamycin gel, Hibiclin, sometimes all of them prescribed for a patient. Your HS patient already has enough to do throughout the day. If you're giving them 2 or 3 topicals that essentially do not much and kind of do the same thing, you're really just making the patient's day a lot more stressful. All you need is one. It's benzoyl peroxide. It's simple, it's cheap, it's accessible. It's, addresses a microbiome. It's keratolytic. It kind of does whatever you would need a wash to do. I think doxycycline is reasonable to start with. I don't think it's reasonable to put someone on doxycycline and just go 2 or 3 years without it really achieving the goal that you want it to. So starting there is okay, but reevaluating every 3 to 4 months for treatment goals is also important. For my female patients, especially ones that may describe flares with cycles, I feel that spironolactone is also very helpful. You don't need high doses. I don't find myself titrating up like I do in some acne patients. 100 to 150 milligrams is usually adequate. Then there's moderate disease, and we're still working on a definition of what moderate disease is. But if we just borrow from the clinical trials for moderate to severe disease, that's essentially 3 to 5 inflammatory nodules or abscesses, and or the presence of either one tunnel or rope-like scar. And I hope that paints a very different picture for you of what a moderate patient looks like, because I know we're all used to seeing the most severe patients. But moderate really doesn't have to mean that huge burden of disease. Just 3 to 5 inflammatory lesions or just the presence of one tunnel or one rope-like scar should invoke moderate disease for you. And when it does, that opens up the patient to more therapeutic options. And those are the targeted therapies alone or even in combination. And we'll talk about that in a bit. Rescues are really important across all levels of severity. ILK and IND you're familiar with. Sometimes we use courses of antibiotics as a rescue. Prednisone for a chronic disease is not something we should lean on, but sometimes it is the only thing that gets a patient some relief. And so I do use it, albeit judiciously, but I absolutely use it when I need to. What does that look like? It's typically 20 to 30 milligrams daily for somewhere around 2 to 3 weeks. And when I'm also using it at that dose and for that period of time, HPA access has not been an issue, and I can abruptly stop without having to taper. Ertapenem is probably the one antibiotic and really one treatment that we feel works incredibly well and reliably so. We can give patients a prediction that it will work. I can't really do that for any other treatment yet, but we're all aware of the importance and need of antibiotic stewardship in this day and age. Our ID colleagues have not embraced this treatment for HS patients. It does require IV access for daily infusions that we do arrange as home infusions. So I think it's really important to kind of think about which patient uses for and when. I think about it as a bridge to some sort of treatment. I'm going to do it for 6 or maybe even up to 12 weeks, but I'm going to have a plan for when I take this patient off, because when they do come off, we know that they recur pretty quickly. And if you're not doing procedures for HS patients, I would implore you to think about this. We used to think about procedures as the absolute last resort, and it's just not the case anymore. You want to find medical therapies that optimize levels of inflammation, just really kind of cool things off, reduce the drainage, but then you really want to be weaving in procedures for individual lesions or even for anatomic areas that are going to do the rest, because we know medical therapy can't fully get there today. What are those procedures? So for individual, isolated, clearly delineated tunnels, deroofing is a simple, quick, easy procedure, which seems intimidating. Not a lot of people are doing it, but it is the one treatment that can take a tunnel from draining, which wreaks havoc for a patient throughout the day, to non-draining when medical therapies otherwise don't achieve that. You can't do it for tunnels that are interconnected or part of a big plaque, because the likelihood of recurrence is just too high with deroofing. And for those tunnels, we're doing excisions with secondary intent healing, excisions by blade, but also by electrocautery or even by CO2. We think use of heat sources significantly reduces recurrence rates. So if you're going to do a big surgery with 3 to 4 months healing times, you want to try to optimize or really limit recurrence rates, and using heat sources, we think, does that. There are videos for de-roofing online. There are also videos for excisions. I would also, I'll put in a plug for the HS Academy, which is the HS Foundation puts together an annual meeting just for residents. It's a soup to nuts meeting on everything HS. We teach a lot about, obviously, medical interventions, but also procedures. It's a supported meeting. I feel like your residents have been to this meeting. It's happening in December in Nashville. And if so, if any of you guys are interested in attending, go to the HS Foundation's website. I think if it hasn't opened up already, the applications are opening up soon, and it fills up like almost right away. So if this is something you're interested in, I would sign up as soon as you can. We have 3 biologics now approved. You can see here their overall responses. All of them have shown durability of response, depth of response, reduction in pain, reduction in flares, and overall improvements in quality of life. Are they perfect? No. Are they the best we have? Yes. Do they do a very good job at controlling day-to-day symptoms? Much better? Absolutely. Do they do a good job at preventing those big flare-ups that puts patients into the hospitals, or at the very least generates calls to the office for add-ons where we don't have room to add on because our offices are so filled? Yes, it does. So if you can control day-to-day symptoms better, if you can prevent trips to the ED or admissions to the hospital or even phone calls to the office, all of these things are great for patients and great for us taking care of them. Think about this again for that new concept of moderate disease. We should be flipping the therapeutic ladder for these patients and using the best treatments we have available at the earliest time that is appropriate. I always talk about the pipeline for an HS patient because it gives all of us hope. And I will say that the pipeline in HS is so robust. There are over 20 molecules in phase 2 or phase 3 drug development. We've had a tough time getting drugs approved in HS because of some of those problems I alluded to in clinical trials, but we're making a lot of progress, and our industry partners are along for the ride in really wanting to try to address what again, as I think is one of the greatest unmet needs in our specialty, which is treatment for HS patients. So you can see here several classes of MOAs. Several of these, I think at least 3 of these are almost done enrolling in phase 3, meaning we may have new approvals for different MOAs as soon as maybe a year from now, on top of the 3 I already mentioned. So we're not in a perfect place, but we've got pretty good targeted treatments, and we've got more on the way. We've summarized a lot of this literature in an article that was just published about a month ago. This is a network meta-analysis. So a network meta-analysis is very helpful when you don't have head-to-head comparisons of drugs. We're probably not going to see that in HS for a little while. So the best we have is indirect evidence, and the way to compare drugs indirectly is through a network meta-analysis. In addition to that, this systematic review is living, meaning we'll be able to update that every year, if need be, as new phase 3 trials report on their results. So this would be a good article for you to kind of think about what treatments might give your patients the best opportunity for success, including off-label ones, which you will have access to. So this is one of the tables. It includes all of the approved drugs, but it also includes all of the drugs in phase 2 or phase 3 drug development as well. Maybe a last concept I'll leave you with as it relates to treatment is combination therapy. combination therapy outside of the specialty of dermatology for chronic inflammatory or severe diseases, for debilitating ones, for ones that result in significant morbidity, even mortality, combination therapy is common and in many cases standard of care. So when we have a disease that fits that bill in dermatology, why should we shy away from it? It shouldn't be because of our general level of conservativeness and hesitancy for being as aggressive as we should be for the right patient. We certainly need the data to be able to arm us with being able to do that. But I would say if there's any disease that I think where combination targeted therapy will be a standard of care in our specialty, it's going to be HS. And in fact, we're already doing this in our practices, and there's some anecdotal data that would suggest it can be very helpful. So for my toughest patients with HS, ones who haven't responded to cytokine inhibitor therapies alone, even infliximab, where I can really titrate up the dosing to 10 mg per kg Q4 weeks, I'm adding a JAK inhibitor, at least the ones I have available to me, which includes upadacitinib, as well as tofacitinib. There are other ones approved for, Areata, and perhaps those might be an option. But I will say that for my toughest patients, when I've added on a JAK inhibitor, I've gotten a significant incremental benefit. My N is low, so I'm not really powered to tell you about safety, but those patients have tolerated that regimen just fine. And lastly, let me just give some credit to a lot of organizations in HS which are supporting care for patients. If your patients don't know about Hope for HS, and if you don't have a chapter for Hope for HS at your site, consider having one. It's one of the greatest support groups that people living with HS can have. The foundation, HS Foundation, does a lot of great work for patients and also in educating physicians around HS, and several research groups also listed here. So with that, I really appreciate your attention. Thank you.
Thank you so much for that wonderful lecture. Apologize, but we're out of time for any questions because there's a UCSD faculty meeting right after. I saw that Dr. Garg kindly offered his email in the end last slide, and we